Okay, good evening, everybody. Welcome to this another session of 45th Comprehensive Course on Echocardiography. Today, we are going to talk about two topics. One is right heart hemodynamics, followed by question answer session. Then we'll have about 10 minutes break. And after the break, we'll show you a couple of live examples of right-sided cardiomyopathies, which was left behind in the previous session. Because it's very important to have a right-sided cardiomyopathies evaluation, because they present in our circumstances very commonly, and where the management is entirely different from a left-sided cardiomyopathies. With this few words, let me go ahead and talk about right heart hemodynamics. What exactly the right heart hemodynamics are, I'm going to show you in a couple of minutes. Here is a picture where we are concentrating more on a right side of the heart. Here's a view. I'll request everybody to please mute their mic. Sincere request to everybody. And I'm sorry to say these words. If somebody does not listen to me, obviously I'm going to shunt him out of this particular meeting. So I'm going to concentrate on my right heart hemodynamics in the sense I'm going to look at what all is there in right heart which helps in determining the function as well as the pressure of the right heart lesions. If you look carefully on this slide, we have this RV, RA which are dilated. You have a significant amount of tricuspid regurgitation in this particular patient. On top of that, in short axis view, what you see in aorta, RA is reasonably normal, but RV is hugely dilated and there is presence of a thrombus at the bifurcation of pulmonary artery. And that important is, like we have this patient in a personal short axis view of papillary muscles, where the septums becomes D-shaped with every systolic contraction. What does it mean by, if you happen to look very carefully, as the LV starts contracting, the interventricular septum becomes flattened out. What does it suggest? That the RV pressure becomes more than LV pressure during systolic. And these are RV pressures, obviously. LV pressure, if you are able to measure them, we can look at these kind of a thing. What is my estimated RV pressures are? That's how we look at these kind of a things in our clinical practice, apart from evaluation of them by 2 dimensions or Dopplers. So, few important things. What is the definition of pulmonary artery hypertension? What are the RV structures, functions, and hemodynamics? Does all method for evaluation of pH are complementary to each other, or they're comparable to MRI and right heart catheterization? Look, at this point only, I would like to say that whatever evaluating in pulmonary artery hypertensions, they have been very well correlated with right heart catheterization as well as MRIs. But MRI and right heart catheterization are the gold standard for their evaluations. So that's the most important thing which you must understand. If we have a doubt, obviously we go ahead and look at right heart catheterization and MRI for further evaluations. All of you understands that mean pulmonary artery pressure more than 25 millimeters of mercury at rest and more than 30 millimeters of mercury after stress is labeled as pulmonary artery hypertension. And what it needs? It needs a pulmonary vascular resistance of more than 3 millimeters per meter square per liter per minute, Woods or Woods unit, and pulmonary capillary wedge pressure of less than 15 millimeters of mercury. PVR more than 3. And on top of that, pulmonary capillary wedge pressure of less than 15 millimeters of mercury. What does it mean by? How do we estimate pulmonary capillary wedge pressures? 2 important things which are going to learn is PVR and pulmonary capillary wedge pressures. Then next comes increase in mean pulmonary artery pressure more than 25 millimeter at rest as assessed by right heart catheterization. And normal mean pulmonary artery pressure is 14 plus minus 3 millimeters of mercury with the upper limit of 20 millimeters of mercury. If somebody asks me what is your mean pulmonary artery pressures are, so at that time, you have to say that the mean pulmonary artery pressures are 20 millimeters of mercury, not 25. 25 is the upper limit of normal. Next question comes, what is there in between 20 and 25? And that's what the answer has been said in this particular paper in 2016. talking about the gap between 20 and 25, that is what they have been talked about. What is this gap of 20 to 25 is? Patient presenting with pulmonary artery pressure in this range should be carefully followed when they are at risk of developing pulmonary artery hypertension, that's connective tissue disorder or family history of heritable pulmonary artery pressures. So if you find a patient whom you expect a pulmonary artery pressures to be on the higher side, but you can't find them on a higher side, but they're normal between 21 to 24, at that time, you should always look for a follow-up of these patients subsequently. And when is the follow-up? Almost every year. So normal is 20 at rest. Greater than 25 at rest is classified as pulmonary artery hypertension. And the same thing has been said in this paper of 6-word symposium of pulmonary artery hypertension, saying that 20 to 24 should be a high-risk patients with possible poor outcome if left unfollowed. Now you can ask me why I'm talking of all these things. Look, you are all busy practitioner in your life, and in the life, you find a patient who has got a normal pulmonary artery hypertension, but patient is symptomatic. At that time, a patient of a chronic obstructive lung disease, patient of many other pathologies, if they have an elevated pulmonary artery pressure, and when you measure them, they come out to be normal, what you need to follow them up regularly over a period of time. Let's look at the evaluation of RV-RA. Mean pulmonary artery pressure is evaluated by M mode, and look at this M mode across plaques view. The septum and posterior wall, they're contracting almost at the same time. But look at this particular diagram over here. The septum is contracting first, then going back again, and then contracting again. That is when we suspect pulmonary artery hypertension or dilated RV. And why does this happen? It happens because of the fact that the patient interventricular septum bulges to normal before contracting. It means to say if it's flattened, it'll bulge towards RV first and then it'll contract later. So same happens, it bulges towards RV first and then it contracts. Then two-dimensional imaging is the most amazing technology to talk of pulmonary artery hypertension. And anyone can understand, normally my LV pressure is more than RV, my LA pressures are more than RA. But in this subject, interarterial septum is bulging towards left-hand side, suggesting that RA pressures are more than LA pressures. Normal LV is bigger than RV. Here is RV is bigger than LV. Here is RA is bigger than L. So without saying qualitatively by two-dimensional image, I can categorically say is that this patient has got something wrong with his RV-RA. And in that wrong, I do not know what exactly the wrong is, but these two chambers, they are dilated, but RA pressures are more than LA pressures. And if LA pressures are almost 10 millimeters of mercury, as estimated by diastolic function abnormalities, certainly the RA pressure is more than 10 millimeters of mercury. That's what suggests. This is a very good slide, which I talked about a few minutes back. Was look at the contraction of septum towards LV with every systole, suggesting that RV pressure are more than LV pressure during systole. It means what? If I take my LV pressure by blood pressure in the absence of any obstruction at the level of aortic valve or any other lesion, if my blood pressure is 110 millimeters of mercury, my RV systolic pressure has to be more than 110 millimeters of mercury. So do I need anything to evaluate? Categorically, I can say, look, this is where my RV pressures, which are very, very well elevated. Then the question comes, pressure oblique volume overload. How do you say the word pressure oblique volume overload? I always tell you, remember one thing. If D-shaped ventricle is present during diastole, it's always a volume overload. And this D-shaped ventricle becomes further D-shaped or flattened during systole, is not only a volume overload, but a systolic overload as well. And that has been said by eccentricity index. RV volume overload is when the ratio is more than 1 during diastole and remains 1 during systole. What does this mean? Eccentric index is? If I go back and show you the same slide again, I measure my short axis dimensions during systole and diastole. So in this short axis dimensions, I go from RV from this point to this point. From this point to this point, my RV is bigger than LV. It means more than 1 in dimensions. And this dimensions remains same during diastole and systole, then is volume overload. And if this dimension becomes more, then is systolic overload or pressure overload. Here is example for that. This is D1 oblique D2. So I can measure D1, I can measure D2. But these are qualitative things. They are not quantitative things. What we need today, if somebody asks you ejection fraction, if you tell them, oh, it's moderately reduced, they said, guide, please tell me what is the ejection fraction is. So what we need to look for their quantitative values. And which I'm going to talk about quantitative values are like RA pressures, RV pressures. So these are the various parameters I'm going to talk about in next about half an hour to 45 minutes. How do we estimate a RA pressure during our clinical times? I still remember I used to raise my hand on the left-hand side, put behind patient's shoulder, raise his neck so that his angle used to become 45 degrees. And then you used to have two friends together, one putting a scale like this, another putting a scale like this and telling you, hey, look, it's 6 millimeters or 6 centimeters of water. And I don't know how many of you must have done it, but I have done it. My boss has done it. And they've told me so categorically, look, this is where you should put our points. And in clinical medicine, we could not pass unless until we show you that RA pressure evaluation or so-called JVP. But in echocardiography is a very simple method of looking at it is mean RA pressure, non-ventilated subject, junction of hepatic vein to IVC in subcostal window. So we go to subcostal window. Here is a hepatic vein with IVC. Here is IVC. Junction of hepatic vein with IVC, and this is the point where we measure dimensions. And these dimensions, once we do an expiration, second we do inspiration, suggesting that how much collapse it has happened with inspiration or not. So, or else many people, what they do in a clinical practice, they put a M-mode line across this. We do often number of times, put an M-mode line like this. And what we get? We'll get an M-mode dimensions during inspiration, expiration, this is inspiration and expirations. And if it is expiration, this is inspiration, we can see a clear-cut collapse of IVC. And based on this, what we do, I'll repeat again where to measure at the junction of IVC with hepatic veins, both during diastole and systole. And based on this, what we now look is, this is a formula which I always try to show, Mere Desh Ka Jhanda. And that Jhanda, what does it says? Less than 21 millimeter size during diastole, collapses less than 50%. It should be more than 50%. It collapses more than 50% in inspiration. The RA pressure is 5 millimeters of mercury. If it collapses less than 50%, RA pressures are less than 10 millimeters of mercury. So you have to remember two important things. One, remember dimensions, that is normal is less than 21 millimeter, collapse more than 50%, RA pressure 5. Remember the other thing, more than 21 millimeter collapse, but the collapse more than 21 millimeter size and collapse less than 50%, then is 15 millimeters of mercury RA pressure. And in between, all variables, they contribute to 10 millimeters of mercury of RA pressures. And this has been said not by me, I'm not a researcher, this has been said by a paper published in 2010, JACE, that's what the answer is. Some people, they take peak, some people, they take a mean RA pressures is 3 and 12. So that's how we look at RA pressure evaluation by IVC. Now the question comes, when my IVC is not seen, it's very difficult problems. And it's very common when we try to see this IVC when the patient is post-operative with all around a bandage on his chest and abdomen. We do a see my IVC. So what do we do? we go to RV free wall TDI and tissue Doppler imaging of RV free wall TDI and tricuspid flow. You look at E wave, you look at the E prime wave of RV free wall. Ratio less than 6 versus more than 6. If it's less than 6, RA pressure is less than 10 millimeter of mercury. If it's more than 6, RA pressure is more than 10 millimeters of mercury. And this is only when the RV functions are normal. Why it's normal? Because the RV systolic and diastolic contraction free wall TDI is dependent on RV function. And it's very well true for ventilated subjects. And I'm sure the people who are doing anesthesia and or critical care, for them it's very difficult to find out in a patient like when we can't see an IVC. But I showed you a diagram. I showed you a live picture where we can see IVC from a right abdomen or right side of the chest to see an IVCs. So this is one measure to look at RA pressures of 4-chamber view with focusing RV free wall TDI and my tricuspid flow pattern. Similarly, you can utilize little higher for all of you. It's not, this slide should not have been there. Anyway, you look at an IVRT of RV free wall TDI. Less than 59, more than 8 millimeters of mercury. More than 59, less than 8 millimeters of mercury is the RA pressures. And third, most commonly things is, if your patient is on ventilator, either you can disconnect, that's what exactly I say number of times, is just disconnect ventilator for a couple of seconds. Look at an IVC size. If IVC is plethoric, it means your RA pressures are high. If your IVC is small in size, your RA pressures are low or less or volume deficit. On the other hand, you can go to hepatic venous flow pattern. And based on this venous flow pattern, what we can look for, what is my RA pressures are. And how do we look at? I'm sure like how do we look at a hepatic venous flow pattern is, we put a sample volume into the hepatic vein, pulse wave sample volume into the hepatic veins. So you'll find all blood which is coming from hepatic vein to IVC during systole and diastole would be seen over here. And with this hepatic venous flow, we can look for systolic and diastolic flow pattern. And we look at a systolic forward fraction in this. What is systolic forward fraction? You look at the VTI of this systolic wave, take a VTI of a diastolic wave. Systolic forward fraction has to be more than diastolic forward. This is very clearly seen. Then it should be more than 55% for a normal RA pressures. And if the RA pressures are elevated, it should be less than 55%. So that is how we look at IVC pressures, RA pressures by various methods in our day-to-day clinical practice. And these are very important. As we said, like why these are important, like because when we are treating a patient in cardiology or critical care or pulmonary anesthesia, volume is very important for this subset of population. Why the volume is important? If you overload them, they'll go into LVF. If you reduce them, they'll go to hypertension. So how do we look at the volume status? We look at the volume status by looking at RA pressures. And as said previously also, if I have to look at my IVC size less than 13 millimeter in size or 12 millimeter in size, then we are volume deficit. And IVC is loaded, like more than 21 millimeters in size with less than 50% collapse. It means we are volume overloaded patient presenting in shock state. I hope that has been clear for all of you, like what exactly do you look for. And that is what exactly is we look for, RA pressure evaluation. But in today's circumstances, before I move to next point is, the most important part for any RA pressure evaluation is nothing else but IVC. Spend time on IVC. Let's move in peak pulmonary artery pressures. And here's a slide for peak pulmonary artery pressure. This is not a focused RV-RA view. What is a focused RV-RA view? Where the RV apex is in this sector over here. But despite this non-focused RV-RA view, we look at the TR jet gradients. We put a pulse wave Doppler spectrum pattern. You find a Doppler flow. Then it cannot be contained. Aliasing happens. Then we shift over to continuous wave Dopplers. So the RV to RA pressure gradient is obtained by measuring the flow of TR jet by CW and incorporating the velocity of Bernoulli's equations. So we get a TR jet velocity. What is the velocity? Is 4V square is a peak pulmonary artery pressure. Mind my word, the word is peak pulmonary artery pressure. Because this is very, very important. We are measuring peak. We are measuring peak TR jet velocity. So we are the peak pulmonary artery pressure, what we are going to look in this subset of populations. Then next issue comes where to measure. If you have a patient of a COPD or lung conditions or anywhere we are looking for a PA pressures, we have to measure them in all 5 windows. Wherever the maximum PA pressures are seen, we are going to take those pressures over there. And normal PA pressures is less than 28 millimeters of mercury, which correspond to almost 32 millimeters of mercury. Or the value, other value, you can say anybody who has got a velocity of 2.8 to 2.9, less than that is considered as normal peak pulmonary artery pressures. And this is a formula which is self-created in 2010, mildly elevated 40, moderately 50, and then severely elevated 60. And to further say this is the guidelines from 2015 European Society of Cardiology and Respiratory Society talking of echocardiographic probability of pulmonary hypertension in symptomatic patient with suspicion of pulmonary hypertension. And look, it's a very simple thing what they said. If you have this velocity of less than 2.9, just be comfortable. And when the velocity touches 2.9, just get alarmed. And why do we get alarmed is, as the velocity goes more than 2.9, then there's no other feature of pulmonary artery hypertension. Just leave it like that, but follow it up. And if you have a velocity more than 2.9 and you have a features of pulmonary artery hypertension like congestive cardiac failure, the probability of deciding about pulmonary hypertension by echocardiogram would be very, very high. So cutoff value is 2.8, 2.9. How do we do a peak pulmonary artery pressure is? We look at a TR jet, we put a pulse wave and continuous wave Doppler, and what we drive is a TR jet velocity. We take a peak velocity of this TR jet, that is 4.64, which contributes to almost 80 millimeters of mercury of peak pulmonary artery pressures. And this peak pulmonary artery pressure, as I said in my previous slide, is if you add air pressure to it, it becomes peak pulmonary artery pressure. So let me just take up this peak pulmonary artery pressure sequence from here and put them over in the next subject. We get a mean pulmonary artery pressures. So I'm going to put this over here and let's see how does it comes up. So I derive the tip of the TR jet velocity. That's 4 into V square plus RA pressure. RA pressure we determine from IVC. So that's how we get a peak pulmonary artery pressures. This one question I always pose to various students, like, does the tricuspid flow Doppler pattern makes any difference for evaluation of peak pulmonary artery pressure? Look, I'll say this particular thing at this point is, this is the tongue-shaped structure. The tip is like tongue shape. And if this pattern changes to rapid acceleration and shorter deceleration time, whatever the gradients are, it's considered as elevated. And if it becomes bifid, it's always elevated or severely raised pulmonary artery hypertension. So this is quantitative and that is qualitative. And this has got a lot of value when we look at a ARVC. In ARVC, what we see always is this kind of pattern when we have a rapid acceleration time and rapid and shorter deceleration time. Next question comes. Does the pulmonic stenosis hamper the assessment of peak pulmonary artery pressure? Is very well said. You look at a pulmonic stenosis jet across pulmonic artery and minus that velocity or gradients from peak pulmonary artery pressure to get a true peak pulmonary artery pressures. Now we move on to mean pulmonary artery pressures. Mean pulmonary artery pressure, as we said, there was less than 40, now is less than 25 to be considered as normal. Anything up to 35 is considered as mild, 35 to 45 is considered moderate, and more than 46 is considered as severe pulmonary artery hypertension. There are three methods of looking at it. One is acceleration time, second is TR jet velocity, and third is the PR early diastolic velocities. At your level, this is the best method which I'll advocate, but I'll show you all three of them one by one. Here is pulmonic flow velocity or RVOT flow velocity. By keeping a sample volume in RVOT, we get a rapid acceleration and shorter deceleration time. So we measure the time from onset to peak, that is known as acceleration time. 80 of half of it will give you a mean pulmonary artery pressure, add by 0.979. So 0.45 into acceleration time plus 79 will give rise to a mean pulmonary artery pressure. On the other hand, when we use doing majority of time echocardiographies, we remember very well when we said 80 minus half of 80. And that's what is 80 is acceleration time, and half of that is minus half of the acceleration time is we get a mean pulmonary artery pressure. So at this point, I'd like to say to put more emphasis because this is dependent on tachycardia to evaluation for echocardiography. Next, a lot of confusion was created at one time was when they started looking at this mean pressure by tracing the jet of pulmonary tricuspid regurg. They said if this is peak gradient and this is mean gradient by tracing the jet, why can't we calculate a pulmonary artery pressure from them? So somebody started in 2009, this is a paper of 2009, he said, let's trace it up, that'll give you a mean pulmonary artery pressure and add RV pressure to it, that'll give you mean pulmonary artery pressure. But over a period of time, that was given up because many people found that that is overestimating of pulmonary artery pressure in this subset of populations. Last method is by looking at the PH jet by PR jet. How do we look at PR jet? Here's a flow across pulmonic valve. There's significant amount of regurgitation. You look at the early diastolic velocity of PR jet, add RA pressure to it, it will give you mean pulmonary artery hypertension. Suppose this is 1.5, 1.5 into 1.5 into 4 is considered as mean pulmonary artery pressures. When so many things were available in the market for estimation of pulmonary artery pressures, then the paper was published in JACE 2018, addressing the controversy of where we can really look at the pulmonary artery pressures. And they looked at all methods, whatever the methods were available, and they said PR jet velocity with regards to its correlation with invasively determined pulmonary artery pressure mean and the presence of pulmonary hypertension is the most important and recommended method for calculation of pulmonary artery pressures. So I showed you three methods. But still, I'll say, if you look at the TR jet peak velocity and add RA pressure to it, that'll give you a peak pulmonary artery pressure. Many people, they say, what is my end diastolic pressure of pulmonary artery? So this is early diastole, which correspond to mean pulmonary artery pressure. This is late diastole or end diastolic velocity of pulmonary regurgitation flow to give rise to end diastolic gradient across pulmonary artery. Give me a second break. I'll just come back in a second. Next comes right-sided myocardial performance index. What is right-sided myocardial performance index is a very simple thing of looking at a right-sided performance index. We have seen this left-sided myocardial performance index. What we were doing, we were looking at a mitral valve closing and opening time, that is known as A, and then aortic valve ejection time, which is known as B. A minus B divided by B will give you a myocardial performance index of left side. If you do the same thing on left hand side, what do you do on left hand side is tricuspid valve opening and closing time, and then pulmonary artery ejection time, and that is A minus B divided by B will give you a right-sided myocardial performance index, and what we call them as tie index, or looking at the function of RV. And this right-sided performance index is very, very important to assess the future prognosis of a patient suffering from chronic obstructive lung disease. Anything normal is known as 0.38 plus minus 0.4. I remember as 42 as a normal to look at this. Anything more than that is considered as poor right-sided myocardial performance index. This can also be calculated by RV free wall TDI. This is tissue Doppler imaging, keeping a sample volume by pulse wave into RV free wall TDI. What we get is systolic and diastolic flow patterns. So what would be the RV tricuspid valve closing and opening time? Here is the A wave closer before isovolumic contraction time. So this is A wave closer, this is A wave, E wave opening. And B is ejection time when the pulmonary valve closes, opening and closes. So we get TVCO by A time from this and B time from this ejection time. TVCO minus ET divided by ET will give you right-sided performance index in this subset of population by tissue Doppler imaging. That was 42. This is 54 as normal to consider as is prognostic significance. Next comes pulmonary vascular resistance in this subset of population. It's a very simple formula to calculate pulmonary vascular resistance. Is a pressure is a product of flow into a resistance, and that's calculated as a Wood's unit. And how do we calculate Wood's unit? It's a very simple formula of calculating Wood. 10 into tricuspid regurg velocity divided by RVOT VTI. Look, we get a TR velocity anyway. We are getting a TR velocity for calculating pulmonary artery hypertension. So it's 2.4 is a tricuspid regurgitation velocity. Then we look at RVOT VTI where we calculate acceleration time. Then what we do? We trace that RVOT VTI. And then the formula is 10 into tricuspid velocity in meter per second divided by RVOT VTI in centimeter. And that gives you a value of Wood's unit in the subset of populations. Is that clear? Because this is how we look at various things in day-to-day practice. Anything more than 3 is considered as abnormal. Then comes Qpqs ratio. Like many people, they must have talked about this Qpqs ratio is QP is RVOT area into VTI, and S ratio is LVOT area into LVOT VTI. RVOT VTI by personal short axis view at aorta, and VTI is by calculating a Doppler flow pattern, as we took a VTI of this particular phenomena of, here is RVOT VTI. So if you have a tricuspid valve over here, so we take an RVOT diameter, get an area into VTI, that'll give you a QP, quantity of blood which is flowing through pulmonic valves. Then LVOT area, all of us have done this, LVOT area by Plaque's window, and LVOT VTI from 5-chamber view or 3-chamber view, we get LVOT VTI to calculate Qpqs ratio, and that's found to be very, very useful. And all of you must have read all these things in the future in previous classes. Is like, based on this, we said this patient has got a significant shunt versus no significant shunts. Now, variables are many because LVOT and RVOT measurements are very tricky procedures. But despite they have definite value of evaluations. Another thing is we can calculate tricuspid regurgitation jet or peak pulmonary artery pressure by shunting methods. What is that shunting method is? Suppose I've got a VSD over here. So this is another part of VSD short axis view, and this is another part of VSD. And once we take a TR jet, once we take a gradient across this, we can calculate pulmonary artery pressures. Now you can say how. This is RV, this is RA, right? If I put my cursor across this RV RA, shunt is there in VSD. So what I'm going to get? I'm going to get a Doppler flow pattern flow from LV to RV. And mind my words, this is LV to RV. Because LV pressure are more than RV pressures. If the pressure reverses, suppose we had that reversal of flow, in that case, the shunt would be seen in other direction. So what we did, we kept a center line across this, and we get a Doppler flow pattern of a gradient of almost 4.43 meters per second. Let's consider it as 5. So the gradient between LV and RV is 5 into 5 into 400 millimeters of mercury. And this is very well true when we talk of pediatric issues. This is very well true because we can calculate pulmonary artery pressure from this. Somebody will ask me, how can I calculate pulmonary artery pressure from this? Look, the gradient is 100 millimeters of mercury. And take a patient's blood pressure. Patient blood pressure is 110 millimeters of mercury. It means the gradient in RV is only 10 because 100 is a gradient. And then 110 minus 100 will give you a gradient in RV systolic pressures. Now, how do we really look at RV function? We have talked about all this RV function before also, but I'm going to talk it again. We look at by TAPSE, we look at RV free wall TDI and 2-dimensional strain. What is TAPSE? Tricuspid annular plane systolic excursion. Anything more than 17 is considered as normal. So we put a cursor line across RV free wall TDI, RV free wall. Then we measure how much this tricuspid has moved towards an apex, and that give you tricuspid annular plane systolic excursions. And when we look at tricuspid annular plane systolic excursion, it has to be more than 17.5 to consider as. Now, TAPSE is more than 17.5 to consider as normal. Similarly, we can look at RV free wall TDI. We can use the short axis view at aorta, or we can use a focused RV RA view. And what we get an RV free wall TDI. Anything more than 9.5 is considered as normal. And you have to take it using end expiration, because with inspiration, it will definitely increase. Last but not at your level, again and again, I'll say, we look at 2-dimensional strain in the RV free wall TDI. Look, this is how the 2-dimensional strain look like when we get rid of RV and we exclusively look for RV for 2-dimensional strain. Anything less than 20 is considered as normal. Here's a film from my own lab where we have taken basal, mid, and apical septums, tissue Doppler strain, 2D strain of these subset of population, and it's come out to be almost 30 centimeters of minus 30 centimeter, minus 30%, which is reasonably normal, and all three segments are contracting synchronously. We do not calculate ejection fraction in RV. Systolic function is evaluated either by TAPSIR or RV free wall TDI or fractional area change in right ventricle. But if you want to calculate 3D ejection fraction in RV, it has to be by 3D only. And how do we calculate by 3D? With normal values more than 45% in RV three-dimension ejection fractions. So various things which are written over here is we look at those dimensions in that particular fashion. So, but we do calculate RV fractional area change in RV systolic functions. Last RV dimensions, as we have told this RV dimensions before, like chamber quantifications. I'm not going to show you these dimensions again. And this is what I was talking about for systolic functions. You look at RV focused view, then in RV focused view, trace the area during diastole, trace the area during systole. It should be less than 35 is considered as abnormal. That is so-called fractional area change. This is RV end diastolic area minus end systolic area divided by RV end diastolic area into 100, which is considered 35% or more is considered as normal of a fractional area change. Then before I close, we have talked this again. We look at RV, raised RV EDP. What do you mean by raised RV EDP? RV EDP is raised. We looked at the RV EDP raised by PRjet. So as RV, LV relaxes, so is the RV relaxes. If RV is pressure is high, it means the relaxation becomes poor. And we can look at this values by looking at EA ratio. And the most important time is the dissolution time of EA wave. Dissolution time, which is less than 180, 119 is considered as abnormal. So various normal RV parameters, which I've showed you already, TAPSIR, systolic, S wave, RV fractional area change, two-dimensional strain, ejection fraction, pulse Doppler, myocardial performance index, tissue Doppler myocardial performance index, E wave dissolution time, EA ratio, E prime A prime ratio, we've not talked about it, E prime and E to E prime ratio. So many factors which can look at RV functional parameters to look for RV functional change. Now this is a slide of a cartoon. He said, sir, how many parameters are these? Are the parameters which I'm going to correlate with everybody? No, it's not true. So do they correlate well with right heart catheterization or MRIs? Well, this is a validation study published in 2012 talking of various methods which I showed you over here. And they calculated very well with RV, RA catheterization as well as right heart catheterization for RV-RA pressures and cardiac MRI for right ventricular ejection fractions. A little words about anesthetics, ventilated patients, estimation of RA pressures, estimation of RA appendage by transesophageal echo, and we can demonstrate right atrial appendix by transthoracic echo also, and bicaval view for RV, IVC and SVC also. How do you estimate RA pressures in ventilated subjects? We always use tissue Doppler, RV free wall TDI, and tricuspid flow to assess ventilated subject RA pressures. And second, we can look at the IVRT of tricuspid flow or RV free wall TDI to calculate RA pressures. Three dimensions transesophageal study for RV and functions. A couple of questions to colleagues is, what is the dimensions of IVC? The dimensions of IVC is 21 centimeter of water or 21 millimeters. Does the Doppler spectrum pattern makes difference in evaluation of peak pulmonary artery pressure? The answer should be yes. And if you look at a Doppler flow pattern, is the tongue shaped. When it has a rapid acceleration time and slower deceleration time, then we call as raised pulmonary artery pressure, and become bifid, that's significantly raised. Does the pulmonary stenosis hamper in PA pressure evaluation? Obviously, we can do it in pulmonary stenosis when we subtract that stenotic pressure from our peak pulmonary artery pressure to get a true pulmonary artery pressures. What is the diagnosis in this patient of plaques window, short axis, and plaques window is the thrombus which is sitting at the tricuspid pulmonary artery bifurcation. It's not seen over here in some of times, but here is a tricuspid, the thrombus sitting over here, and a patient presenting with acute raised pulmonary artery pressure. Doppler strip, it does tell you a lot of things in Doppler strip here. With inspiration, the flow is increasing, the expression, the flow is decreasing. And when we take a next subject sometime later on, when we're talking about constructive versus restrictive cardiomyopathy, then this thing will become more appropriate, looking at a respiratory flow in tricuspid and mitral valve. Amongst all methods described for RV function evaluation, which is the best method to correlate RHC with MRI? Is it TAPSE, RV free wall TDI, two-dimensional fraction area change, or two-dimensional ejection fractions, or RIMP? Then right heart catheterization evaluation is extremely important before, during, and after cardiac surgery. Intelligent understanding of hemodynamics is important for better outcome. And last one word is when we're talking of pre-capillary versus post-capillary. This slide is slightly poor, but I can say in one simple word is, like, if you happen to look raised pulmonary artery pressures due to elevated LA pressure, that is known as post-capillary. Look, if you have patient of mitral stenosis and mitral regurgitation, what will happen? Ultimately, they develop a raised pulmonary artery pressures. And if you evaluate a diastolic function of left side in those subset of populations, the diastolic function says elevated LA pressures. And where does this elevated LA pressure reflect to? Right side of our heart. So that post-capillary raise of pulmonary artery pressure is known as post-capillary, and without any significant elevation, without these factors known as pre-capillary, when RV are systolic pressure by per se, by themselves, they are elevated. So with this, I'll put a stop over here for my talk and then take up a few questions from all of you one by one, so that try to understand what exactly we have learned over a period of time in this particular session. So next topic which I'm going to talk about today is right-sided cardiomyopathies. Why these cardiomyopathies are important on right side is, that's what will be shown adequately once you go through this topic. At this present moment, it will not be possible to tell you yes, why they're important, but certainly they have a significant value when we talk of right-sided cardiomyopathies. In general terms, what is cardiomyopathies is, we always appreciate that they are the diseases of heart where the walls of the heart chambers become stretched, thickened, and stiff, leading to inability to pump blood around the body. But when we talk of all these things on the right side, when we say not around the body, towards the lungs. And in this type of cardiomyopathy, when we had talked left-sided cardiomyopathy, we talked dilated, hypertrophic, restrictive, non-compaction. Then couple of right-sided cardiomyopathy, which I'm going to talk about, apart from arrhythmogenic right ventricular dysplasia, is Restrictive, again, endomyocardial fibrosis, amyloidosis, ARVC, the most important thing, along with Ull's anomaly. Then right-sided cardiomyopathy post-BMV, which is, we still see a couple of patients presenting to our OPD. Then Carcinoid Syndrome and isolated non-compaction of right ventricle. Let's start with this particular first case. This is from our own lab, done in 3rd March 2021. This is a lady of 75-year-old, and look at, she's diabetic, she's hypertensive. She had a history of a coronary disease. She's a non-smoker, non-alcoholic, not obese, no hypothyroidism. She does not snore, but in ECG, she has got an atrial fibrillation. Her weight is approximately 75 kg and height is 140 with approximate body surface area of 162 and heart is 80 beats per minute. So here is a plaques window as it is, like LA, LV over here, RV on top, and we are focusing on mitral valve. Now we are focusing on aortic valve where we see a trivial aortic regurgitation. Measurements of LV, they're high normal, 32 millimeter per meter body surface area. And I always ask you to remember measurement in indexed, 32 in LV, 22 in LA. And if you look at an LV wall thickness by this particular plaques method is 13.7 IVS and posterior wall is diastolic systolic. Posterior wall is 10.61. So septal is little hypertrophic, but posterior wall is normal. We look at an LA, LA's indexed is 32. So LA is dilated as seen over here. So with this, we understand that LV is normal in size, almost normal wall thickness except septal hypertrophy, but dilated LA. Pulmonic flow velocity is almost normal, 0.74. And this is a characteristic feature of two dimensions, four chamber view. Look, LV is normal in size, LA is dilated, RA is dilated, this small pericardial effusion over here, thickened calcified aortic valve, annular calcification appears to be there. Then small amount tricuspid mitral regurgitation. Mitral flow pattern is definitely significant, suggesting that tall E wave and a very small A wave seen over here. And deceleration time is 146 milliseconds, suggestive of restrictive filling pattern, E ratio more than 2, and deceleration time less than 150 milliseconds, suggestive of restrictive filling pattern in this patient. We look at E prime, septal E prime, which is 5, lateral E prime, which is 5, average is 23.59, very high. Anything more than 14 is considered as abnormal. And color flow propagation velocity is 46, which is in mid-range. Normal is more than 55, poor is 30. So somewhere in the mid-range. And LA volume is again elevated as 41.4 ml per meter body surface area. Anything more than 32 is considered as abnormal. And if I put all these parameters with this diastolic function evaluation, let's took one by one. E wave 1.12, A wave 36, a ratio is 3.13. Is 3.13 classified into grade 3? Then E2 prime average, where is classified into grade 3? Then LA volume 41.4. LA volume increased 41.4. Then TR jet velocity, we have not taken a TR jet velocity till date, but we'll take TR jet velocity. Till now, we say grade 3 diastolic dysfunction with elevated, with raised or elevated LA volumes. What does this grade 3 classifies into? LA pressures are almost 15 millimeters of mercury or elevated LVTP. And if this patient goes to atrial fibrillation, which he went to subsequently, we look at this parameter of IVRT, which is close to 65. E to E prime ratio, EVP ratio is 1.4. This is EVP ratio is 2.43. This is velocity propagation velocity. And septal E to E prime ratio average more than 11, it was 23. Even in atrial fibrillation parameter, it shows restrictive filling pattern or elevated LVDP. Aortic flow velocity, we can say normal. And then we went to tricuspid flow velocity. Here is a T wave of multiple magnitude. Now you look carefully of these T waves. Some is smaller, some are taller. And why they are smaller and taller? Because this is during inspiration, during expiration. So you don't measure the inspiration, we measure the end expiration. And now look at a TR jet velocity. As somebody asked this question very critically, I'm going to show that. Now look at this point. This is a tip of the TR jet. Now this tip, sometimes look, you can measure over here, you can measure over here. And this is, we have measured over here. This is overestimated. Now somebody asked me why these few patterns. They are all respiratory variations. If I'll measure over here, I'll be overestimating if it's inspiratory phase. So we have to measure when we have a quiet respiration, when we have not inspired during end expiration. And if I measure over here, look, this is 3.2 and over here would be 2.7. And we have to see a quick or cut-off TR jet sample volume. So the velocity is 3.2. And if you put up this velocity of 3.2 into these parameters of TR jet, it's again 2.8. So definitely this patient has got grade 3 or restrictive filling patterns. Now, another thing which I've said, looking at the systolic function in tissue Doppler. So this is S wave of mitral annulus, this is 5. S wave of lateral annulus is 4. S wave of anterior annulus, inferior annulus is 4. S wave of anterior annulus is 6. S wave of posterior annulus is 5. So all velocity, they are uniformly 4, 5, 4, 5, suggesting that now LV function is normal, but has got some reduction of LV systolic function. But RV systolic function is 9.5, which appears to be little preserved. Subcostal window, we small amount of pericardial effusion. And somebody was asking where to measure the RV free wall TDI. Let me just hold on this film over here. This is tricuspid valve, and this is RV free wall thickness. You can measure it over here. So this is opening of tricuspid valve seen over here. So almost this is mid segment. You can measure this RV free wall thickness from this point to this point. Look at the change of rhythm of a patient. The patient who was normal suddenly became atrial fibrillation. TR jet velocity, variable. And now this is atrial fibrillation. There is no RV apex obliteration. RV apex is reasonably normal in this patient. There is no obliteration of RV apex. Similarly, we went on to see a 3-dimensional echo. There is no RV obliteration. LV obliteration, again, it was not there, LV obliteration. So patient has got a features of IVC plethora, dilated IVC, which is collapsing less than 50%. We cannot measure over here. We have to measure at IVC where hepatic vein joins. So this is a place where I'll measure my IVC diameter. And look, it appears that IVC is normal, but it's not true, because where we are measuring is, we have to measure at this point, not at this point. So the features are restrictive cardiomyopathy. What are the features of restrictive cardiomyopathy? Normal LV RV size, dilated RA LA size, normal LV RV systolic function by 2 dimensions echo, and there's feature of elevated LVDP and RVEDP also by echocardiography. LVDP I could show you over here. RVEDP we can measure in this patient by going back to a very simple formula, and which I'll show you right now here. It should be very intricate. Like this is, suppose I'm taking this wave is, E wave is 93. And this dissolution time is 256 milliseconds. If I divide this E wave to RV free wall TDI E prime, so this is RV free wall. I'm measuring systolic wave. Let me measure the diastolic wave. This is more than 10, is almost 10 to 12. I'll say 12. So this is 12 and this is 96. So this is 93 divided by 12 would be more than 6, suggesting that RV-EDP is on a higher side. And we do expect RV-EDP to be higher side because RV-EDP is a measurement of, in like this cases where TR and MR is present, with the filling pressure to RV would be elevated. So we have elevated RV-EDP, we have elevated LV-EDP, we have a dilated LA, dilated RV, and patient has also gone into atrial fibrillation. And these are the features for restrictive cardiomyopathy with no RV apex or LV apex obliteration. If the same patients, if you happen to find RV-LV obliteration of apex, this is known as endomyocardial fibrosis. Look at this patient who has got a RV obliteration of apex with significant amount of tricuspid regurgitation. Now the NSR is maintained, but this patient is endomyocardial fibrosis. Next question comes as amyloidosis. Amyloidosis is not a rocket science, but you look at this amyloidosis versus the previous picture of restrictive cardiomyopathy. Look at this picture, despite so many of our gains over here, look at this picture of amyloidosis over here. As if somebody has increased the gains of every structure, whether the LV, interventricular septum, posterior wall, mitral valve, aortic valve, leaflets, everything appears to be very, very thickened. Look at the thickened calcified kind of a thing of papillary muscles. Now look at this image very carefully. Everything appears to be so thickened, and even the LV hypertrophy which is present over here, and this kind of a picture with small pericardial effusion over here and IVC seen over here. This picture is like everything is hyperechoic. And when you see this picture hyperechoic with a feature of restrictive cardiomyopathy with elevated filling pressure, always think of amyloidosis. Look at this granular kind of a structure of interventricular septum and posterior wall. And in today's circumstances, we do a two-dimensional stain in this subset of populations, and we find this apex which is spared as compared to periphery. We have a suspicion of amyloidosis. And this is one paper which we published in our lab, where we looked at certain subjects of patient with LV hypertrophy. Apical sparing was present in about 2 patients out of 10. 6 patients had that differential cyanosis, differential two-dimensional stain, and 6 was normal, 4 were normal. And we could pick out these out of 10 subjects, 2 were having suspicion of amyloidosis. So if you look at this two-dimensional stain, that gives you a characteristic picture that patients are having possibly an amyloidosis. And if you believe my words, one literature published in JAC 2019, when we were talking of aortic stenosis, they say almost 17 to 19% of patients of aortic stenosis, they have significant amyloidosis. So thickened walls, thickened valves, normal LV-RV size with normal LV-RV systolic function, but definite restrictive filling patterns. And I always compare this amyloidosis with this picture of 1969 Macanus Gold. I don't know how many have seen this picture because most of you are pretty young, not close to 50 at all. And this is when this Gregory Peck and his team goes to a valley, and they're sitting on top of a valley when the sunrise rises and falls on the valley sparkles like anything because of presence of diamonds and gold. And that's picture adequately I always remember. If you happen to see amyloidosis once in your life, as you must have seen these pictures, you will never forget amyloidosis because everything is so brightened up. Like I always, when I teach my students, I say, look, the diamonds are sitting over there. All these are diamonds. and the light is falling on those diamonds and reflecting to us, suggesting that this is amyloidosis, and corresponding very well with this Maconas gold picture, which was shot at in 1969. Let's move on to another case of right-sided cardiomyopathies. You must have often seen this kind of an ECG. And if you carefully look at this ECG is something a very unique kind of a pattern of this ECG. I'll come to this in a couple of minutes. And this patient, when we were examining this patient, suddenly went into this aberrant rhythm. And this aberrant rhythm is like LBB kind of a pattern. Look at this widened QRS complex on the left-hand side. And here's a picture of this patient of echo once we revived this patient. This is RVRA, which is dilated, and you see so many diamonds and gold sitting at the apex of RVRA. But the diamonds and golds are not there in the RV valves, not on the walls, but they are sitting in the apex and RVRA, which is dilated. And same thing is, this is modified plaques view where LA is seen over here, LV is seen over here. And this is short axis view where we will talk about RV diameter is more than LV diameter. Similarly, this is again a picture of RV apex. And when we put a color Doppler pattern in this, look very carefully. The severe tricuspid regurgitation jet is present. But you look at the gradient is hardly 2 meters per second. And if you look at this carefully, let me zoom it up for you. Look at this pattern of TR jet velocity. This is not a typical tongue-shaped pattern. This has got a very sharp acceleration time and slower deceleration time. Look, this is very sharp acceleration time, and sometimes this beats appear to be bifid, or the deceleration has got a notched kind of a pattern. And this is what is velocity is hardly 2 meters per second, and this is respiratogram. When you find this kind of a pattern with this TR jet velocity and with those kind of a patterns of tricuspid RV apex, we should always suspect what? We should suspect ARVC. So we have dilated RVRA without thinning of RV free wall, reduced RV systolic function by TAPSE, severe TR jet with normal RVRA systolic gradients, LV-RV ratio is more than 0.5, and very tuberculated band filling almost whole of our RV. We should always think of ARVC as a possible diagnosis. In contrast, Wool's anomaly, the RV free wall thickness becomes smaller. It's not thick, it's thinned out like a paper. So that becomes Wool's anomaly, a variety of ARVC which present with right-sided cardiomyopathies. And why I'm going to spend a few minutes more, because this is very important modality presenting in life, because the majority of patients are asymptomatic and they present only with 2 symptoms of palpitation and syncope. Why this happen? Because the RV apex, this fibrous fatty tissue is replaced by the fibrous tissue is replaced by fatty tissue, which replaces the normal heart muscles. And they become a source for arrhythmias or dysarrhythmias. This is autosomal dominant inheritance, clinical manifestation in adolescence and adulthood age with male predominance. Normal physical exercise, TR jet velocity is there. Severe TR there, velocity is not there. They present a syncope and palpitation. Sudden cardiac death is very, very important feature in this subset of population. Hence, AICD is the treatment of choice. And what is most important thing is this is epsilon wave, which is seen over here. And this epsilon wave, if we compare this with cardiac sarcoidosis, look, this is what the classical epsilon wave in this subset of population is. In cardiac cirrhosis, we have this kind of a pattern versus this kind of a pattern in ARVC. So if you happen to see a patient who comes with palpitation and with this kind of an abnormal ECG changes, always look for an echo for ARVCs. And they often have left frontal branch block kind of a pattern of tachyarrhythmias. And apart from echocardiography, cardiac MRI has come out to be a very well modality, which helps you almost to complete diagnosis. And final diagnosis almost come with endomyocardial biopsies. We cannot ignore these patients because they are patients with a very high risk of tachyarrhythmias. As I shown in the picture, when we were examining the patient went into tachyarrhythmia, reverted by DC shock. So we either use them sotalol or amiodarone, or we do a radio frequency ablation, which is not always easy. And majority of the time, the patient they land up with ICD implantations. Next important thing is post BMV cardiomyopathy, balloon mitral valve cardiomyopathies. This is a patient of mine who had mitral stenosis with aortic stenosis. She got her BMV done, and now she is presented with, now you can see an aortic regurgitations. Mitral valve is still thick and partly opening with a significant gradients. And look at a dilated RV-RA. And with this dilated RV-RA, she was persistently presenting with right-sided failure despite normal mitral valve, or not normal, near normal mitral valve. IVC is plethoric. So in whom we should subject in this population? This is no more happening because these are the people at one time about 15 to 20 years down the line, we were not addressing these people of BMV on right side. They had at that time very high TR-jet velocity gradients, and their RV, annulus tricuspid annulus diameter, was very high, like more than 22 millimeter per meter square or 40 millimeter of absolute values. Now, in these circumstances, if we happen to see a patient of mitral stenosis where we're doing a BMV, we do a tricuspid annuloplasty in this subset of population today, so that they do not go into right-sided cardiomyopathy post balloon mitral valve arteries. Or we replace this valve with a low-profile valves. That's what we have been doing if we are doing a mitral valve replacements. Carcinoid syndrome is a very important modality which often seen rarely but not truly. Is a tumor when it spreads to liver and releases a lot of hormone like serotonin into the bloodstreams. It also happen in people with lung and pancreatic carcinomas, but this is rare. So what is exactly the pictures of this carcinoid is? These people, they present with dilated RV-RA with significant deposition of tricuspid valve, presenting as tricuspid stenosis and regurgitations. And once we go to the right side further, they have significant pulmonic stenosis, regurgitation, and look at this Doppler flow pattern, which has got a sharper exudation time. And that's why this serotonin, once it gets into liver, it spreads to the liver and isolatedly involves the right-sided structures. And in right-sided structure, obviously the blood is coming from IVC to RA and RV going to pulmonic valve. So in fact, involve tricuspid as well as pulmonic valve. On the other hand, the generalized involvement on aortic and mitral valve is not rare. It can involve, but this is the two features presenting with this in carcinoid syndrome. Evaluation is by looking at this HIAA levels. Normal is 2 to 9 milligrams. Anything more than 24 hours, more than that is considered as abnormal. That's serotonin metabolites. Non-compaction of RV is a very rare thing. It can happen with LV or isolated RV. Look at this is the non-compaction which I showed you earlier, and here is a non-compaction of RV itself. So not only the LV function which is down, but the RV function is also down in this subset of populations. So it is a myocardial disorder, and as I said previously, we look at the compacted versus non-compacted segment. The ratio should be more than 2:1. So this we look at not in LV, we look at an RV. And this is a feature which is often seen both LV and RV, and it can be present in either formats. With this, I think let me say thanks and for patience hearing. And I'm sure the time of dinner has gone away, and everybody must be waiting for having a dinner. It's almost 11 o'clock at your time. So I'll stop it over here because this is just an overview of all the important cardiomyopathy on the right side which we encounter in day-to-day practice. So I'll stop my slides over here and anybody can open one by one their mics and we can take up these questions for everybody so that